Bioethics 2.0, Podcast Episode 13, Forgoing Life-Sustaining Treatment. Forgoing treatment.
So there are two focuses for this topic. We want to cover decisions not to start treatment as well as withdrawing treatment, which is when you have already given treatment to someone but decide to take it back. These topics pertain when the patient is seriously or irreversibly incapacitated or was never capable. The hardest cases will have many characteristics combined, including technical uncertainty, meaning that there is a prognosis or treatment that is uncertain, or we are not sure what the outcome will be. When a patient is in pain that's uncontrollable and is in a tremendous amount of suffering, a patient who is going to have either currently a poor quality of life or with continued treatment will have a decreased quality of life. When there's costly technologies, when there's a probability of death without treatment. If you have all these things, you have a very difficult situation, and you need to make the decision whether to even start treatments or whether currently burdensome treatments should be withdrawn.
The support study.
The study to understand prognosis and preferences for outcomes and risks of treatment, otherwise known as the support study, conducted in the 1990s, was one of the very few prospective ethics study that's ever been done. It's considered the gold standard. In this study, they randomized people to this, that, and the other, then interviewed them to see if they were in pain. Did the nurse or physician talk to them about the end of their life? What were their preferences? Did you think that your healthcare team communicated well with you? These were some of the outcomes they tried to measure. I will sprinkle the results of this particular study throughout this podcast because it's an important topic.
History of the problem.
I'd like to take us back to the ancient Greeks, most particularly Hippocrates. He actually said a lot of things, and I'm going to be borrowing from the great bioethicist, Dr. Edmund Pellegrino. He's a scholar of this particular area, the history of medicine. Hippocrates said, quote, "As to diseases, make a habit of two things, to help or at least do no harm," end quote. And that is where we get the ethic that governs our healthcare interventions that says, do no harm, primum non nocere, which is the Latin. And this is a corollary of the principle of beneficence. Hippocrates also advised his students, when the disease advances, quote, to refuse to treat those who are overmastered by their diseases, realizing that in such cases medicine is powerless, end quote. So as I mentioned, there are things that we can do for you, and there are things that we can do to you. Hippocrates is talking about the things we do to you. Caring is something that we do for you, and we never stop doing that. But we reach a point of treatment where we don't think we have anything that will work any longer, so we can withdraw those treatments. But ethically, we never stop caring.
The present.
So let's fast forward. There are at least three factors that contribute to the high incidence of cases that involve the decision to forego life-sustaining treatment for people who are incapacitated. We have seen the rapid growth of technologies for critical care medicine and the changing role of physicians, including the expectation that physicians control these technologies. For nurses, it's become much more difficult. Nurses are largely in control of much of the technology in today's healthcare environment. You have to be knowledgeable about ventilator settings, in addition to all the other things about meds. I was at a lecture a little while ago where one doctor was talking about 25 years ago when they had not only to draw their own labs, but also do their own assays. So they had to figure out salt concentration and blood cholesterol, all of those things they had to do. So they had to be excellent chemists as well as excellent clinicians. Of course, today we have automated technology, but we also have an increasing number of incapacitated patients in hospitals and nursing homes. And we also have a cultural demand to use these technologies to prolong the lives of dying patients. The increasing number of incapacitated patients.
One of the reasons we have a growing number of incapacitated people is because we have an aging population. A second cause is that we have gotten really good at saving people from disastrous consequences like head trauma, stroke, alcohol, and other substance abuse. We can prevent patients from dying, but we often do not improve the quality of life afterwards. The fastest growing age group in our population is the age of 85, and that's a large number. With this phenomenon comes a percentage of patients with diminished capacity due to dementia, Alzheimer's, and other age-related diseases. Moreover, we have all these critically ill patients who are often incapable of communicating. they're either obtunded or they're unconscious, and they have traumatic brain injuries. All of these things are a result of the health care that we give people. Prolonging life.
We have already noticed that we in America are more aggressive at caring at the end of life than other cultures. The findings reported by the support investigators provide empirical confirmation of these observations. The other findings from support also confirm that the term life-sustaining technology may be misleading. We can rescue people from grave illnesses, but what we don't do a good job of is explaining to people what happens after that. Most people want to be saved. The likelihood is they want to be resuscitated. But imagine that it's your grandparents. We may not want to do that for our grandparents, because some of them might not be with it mentally. Some may have expressed the desire to succumb to their disease. So we don't do a good job of telling people what happens afterwards. What are the consequences of giving life-sustaining treatments? Sometimes they can cause needless suffering. I don't know how many of you have ever witnessed CPR in someone of advanced age, but the likelihood of breaking ribs is high. Not only that, but the immediate consequences of CPR are overrated. Popular depictions in television don't help. It makes it seem like 50% of people who come in and arrest walk out of the hospital, but in fact the real data is more like less than 1%. So we are prolonging people in persistent vegetative state and are keeping people alive who may not have meaningful existences. And some think we should have a culture change where we don't give all that technology to people for whom it doesn't benefit.
History continued.
There is an older guideline, widely regarded as outworn, which is based on the distinction between ordinary and extraordinary or, quote, heroic treatment. It says we should do only the ordinary things. We shouldn't provide people extraordinary treatment. But that concept wore out because of the changing perception of extraordinary as medical technology advanced. The example I like to use is ECMO, extracorporeal membrane oxygenation, which is essentially bedside heart-lung bypass. And we do this procedure fairly commonly in adults. Years ago, it was considered extraordinary. Maybe it was used in the OR, but now we can do it at the bedside, and that's simply amazing. So the distinction between what is or should be considered ordinary versus extraordinary no longer makes sense.